Thank you, Shafia, and it's a real pleasure to do this webinar for Endo UK. As Shafia said, I am a consultant gynecologist in Aberdeen and an endometriosis specialist. And we do have red weather warning here today and tomorrow, so the weather is really miserable. I hope it's a bit better where you're joining from. So I have a little presentation, so I'm going to share my screen. And if there are any medical terms, I will try and explain them in simple language, but you can always ask me later on once we finish the presentation. Okay, so I am now going to share my screen. Shafia, can you just confirm that you can see my screen?
I can, yes, yeah.
Okay, all right. So basically today we are talking about endometriosis recurrence or recurrence of pain and how best to deal with it. These are just my declarations. So we know that women with endometriosis have a long journey. It approximately affects 1 in 10 women, but we do not know what is the true prevalence of endometriosis, the reason being it's so difficult to diagnose. Most of the times, the common symptoms are painful periods, chronic pelvic pain, painful sex, and infertility. And it can take up to 8 years to diagnose. As you can see, there are lots of misdiagnoses, and there are multiple reasons. One of the main reasons being it requires a keyhole surgery or laparoscopy to confirm or exclude the diagnosis. But the journey doesn't end there. There's a further long journey. There's no known cure. And despite medical and surgical treatment, there is recurrence of pain. A vast majority of women will come back with recurrence of pain after endometriosis treatment. So when it comes to management of endometriosis, there are 3 main goals. One is obviously to reduce pain. The second is to improve fertility in those who are trying to get pregnant. And the third goal is that after treatment, we want to delay recurrence for as long as possible. And I'm going to talk about how we do these things. Sorry, it's not working suddenly. There we go. So there are 3 ways of treating endometriosis. Well, in fact, mainly 2 ways. Surgery is the mainstay of diagnosis and initial treatment. A lot of the time, your surgeon will do what we call see and treat. So if they see there is minimal, mild, and up to moderate endometriosis, they may treat it at the same setting. But if it's severe endometriosis involving bowel or other organs, you may have a second stage surgery. The other option is medical treatment. So usually it is hormonal treatment. It can be started based on an empirical diagnosis or a suspected diagnosis of endometriosis even before you have a laparoscopy. So you may be given hormonal contraceptives of various kinds. But also after surgery, for those who are not trying to get pregnant, we recommend using some hormonal treatment to prevent recurrence of endometriosis. But despite all this, recurrence happens and it remains a formidable challenge. So this is some data here about recurrence. As reported in literature, nearly 40 to 50% of women will have recurrence of pain within 5 years of surgery to treat endometriosis. I also did a survey of women through Endo UK. This was back in 2019. And 93% reported that there was some recurrence of pain after surgical treatment or medical treatment. And for 87% of people, it was within the 2 years of treatment or 2 years of surgery. There's another research which I did where I looked at all women who had a new diagnosis of endometriosis over a 30-year period in Scotland. So it was 17,800 women, and we looked at their outcomes going forwards. So nearly 2 out of 3 women had a repeat surgery, nearly half had more than 2 operations, and a quarter had a hysterectomy with removal of ovaries. So sometimes when the pain comes back, there are many questions that come to mind. is it really recurrence or is it persistence of symptoms? Did the pain even go away completely after surgery? And for some women, it won't. And I must say, when I use the term women, I mean those who identify as women or were assigned female sex at birth. The other question that we think about when somebody comes with recurrence of pain is endometriosis definitely the cause of their pain? Because we do know that there is what we call asymptomatic endometriosis. So people may have endometriosis, but no pain or symptoms. It often comes to light when they're having some other procedure and you find they have endometriosis. In some cases, it can be actually the cause, but in other cases, it could be contributory to the pain with other conditions also causing pain. So people can have more than one cause for pain. And we should be mindful of other conditions too. So when it comes to management of recurrence, it is much more difficult than your initial diagnosis and treatment. It really requires a holistic approach. And there are three main strategies. One is about disease modification, that is dealing with endometriosis itself, which is usually either a hormonal treatment or surgery. But another important aspect is pain management. And there are three types of medications that are used. There are analgesics, neuropathic agents, and there's some novel treatments which are coming on, and we're going to be doing a research trial on that, which is using cannabinoids. It is not yet licensed in the UK. But most importantly, it is important to inform women about self-management strategies so that that can improve their quality of life and make the disease symptoms more manageable. These may include diet, mindfulness, exercise, CBT or support groups. And this is a very important aspect because the disease does not have a cure. So people have to learn to manage it. Now, if you look at the guidelines about treatment of recurrence, unfortunately, there aren't any. So there are two major guidelines used in the UK and Europe. These are known as NICE guidelines and ESHRE guidelines. So what NICE has done, it has lumped suspected, confirmed, and recurrent endometriosis all together, and the same options are offered again to the women, which is very difficult. I mean, most people have already tried a number of hormonal contraceptives, have had surgeries, and they're back with pain. They're literally back at square one because we are offering them the same treatments again. Similarly, ESHRE has said any hormonal treatment or surgery can be offered again. So literally, it's going through the whole circle again. So this is just a graphic representation of what I've just said. So when it comes to pain, it's analgesics, hormonal treatment, and surgery. But very important to take into account individual preferences, how they tolerate a particular treatment, because not everyone can tolerate hormones, whether they're trying to get pregnant or not. And in some countries, costs may be a consideration, though not in the NHS. So these are the various hormonal treatments which are usually discussed. The first line ones tends to be contraceptives, usually the combined hormonal contraception. It can be an oral pill or a patch or a ring. We can also ask sometimes women to use it continuously so they get less number of periods a year. So they can tricycle it, like take 3 packs together. And this helps decrease the period pain by having less number of periods a year. The other option is progestogen. So there's a whole range of medications that fall into this category. There's a progestogen-only pill or mini pill. There's the Mirena coil, implant, and also the injection known as Depo-Provera. They all come with their own side effect profile, and usually it is by a bit of hit and trial, we have to figure out which one works best for a particular person because no two people are the same. The second line options are generally GnRH agonists, and the new drugs which are now available are antagonists. They both work in a very similar fashion. They suppress the ovaries. So endometriosis is an estrogen-dependent condition. That's why it occurs between puberty to menopause. And symptoms tend to settle after menopause in most women. So what these two drugs do, they suppress the ovaries, And due to lack of estrogen, the endometriosis shrinks away, and that improves pain. The last class is aromatase inhibitors. This is not readily available in the UK. It's often used as third-line treatment when pain is not responding to any other conventional medical methods. So people often ask, which hormonal treatment should they go for? And unfortunately, there is no clarity regarding which is the best treatment. So what NICE did was they compared the various treatments with each other and with no treatment. Not surprisingly, all treatments were better than no treatment, but they found that the magnitude of effect or improvement in pain with any kind of hormonal treatment was very similar. And marginally, they found that the Mirena coil, danazole, which is rarely used now, and GnRH analogs have the highest possibility of being one of the best when it comes to reducing pain. Now, talking about GnRH antagonists, they are very effective, but they're not popular. And this is because of the side effects. They're often used as a second-line treatment. So generally, when people present with recurrence and not as a first-line treatment. And then what they do is they cause reversible medical menopause by suppressing the ovaries. So not surprisingly, the main side effects are menopause-like symptoms such as hot flushes, night sweats. In some people, they can affect the mood. In long term, they can cause thinning of bones, and that's why they're licensed only for 6 months. But when combined with a small amount of HRT, not only does that help to reduce the side effects, but also prevent thinning of bones. So they can be used for a longer period of time if HRT is given alongside. But there's still limited data on this, so there's a lot of anecdotal evidence, and it's been used widely beyond 6 to 12 months, especially during COVID, when access to surgery was reduced. So I won't go into the detail of this table, which just tells us difference between agonist and antagonist. The antagonists are not available in the UK at present, but one of the main advantages of them is they're oral tablets compared to the currently available GnRH agonist, which have to be given as an injection or a subcutaneous route or through a nasal spray. So repeat surgery, that is extremely common when people come back with recurrence and we have exhausted a lot of other options, such as they've tried a whole host of hormonal treatment, then often the default option is repeat surgery. It is, however, interesting to note that repeat surgery may not necessarily have the same outcome as the first surgery. In fact, our data from BSG shows that repeat surgery is less effective, and the effect is also shorter lasting when compared to the first surgery to treat endometriosis. There are two kinds of operations. One is just laparoscopic removal of endometriosis, or which we call excision or ablation. And the other one is where we do pelvic clearance. So we excise endometriosis combined with hysterectomy and or removal of ovaries. There, as I said earlier, there is insufficient data regarding efficacy of repeat conservative surgery. And as in a small proportion of women, when they have a repeat procedure, endometriosis may not be seen. Now, what does the literature say? So there are very few studies, and one of the studies compared laparoscopic treatment to endometriosis with hysterectomy and hysterectomy with removal of ovaries. And it was found that hysterectomy with removal of ovaries, when combined with excision of endometriosis, carries the least risk of recurrence. So if you look at the third column here, by 7 years, nearly 55% of people have had repeat surgery if they had excision of endometriosis alone. It is 23% if they had hysterectomy, but kept the ovaries. And if ovaries were also removed along with hysterectomy, then only 8% had repeat surgery within 7 years. Conserving ovaries can increase the risk of recurrence, but removing ovaries can cause premature menopause. There's not a straightforward answer. So I think removing hysterectomy and removal of ovaries is not a choice for many young women who have not completed their family, or some people just wouldn't want to have this major surgery. There have been no trials or research studies, big research studies, looking at management of recurrence of endometriosis. So from Aberdeen, we are leading the Regal trial, which is about recurrence of endometriosis, where we compare repeat surgery, which is often the default option, with long-term GnRH analogs alongside HRT. So this is the first multi-center trial. Women are closely followed. They are eligible if they've had a previous surgery to treat endometriosis, irrespective of the site or the stage of the disease or the number of operations. They either get GnRH analogs with add-back HRT for 2 years or a repeat surgery. We also follow them up with DEXA scans. So these are X-rays which help us determine the bone mineral density, which is done at the beginning and at the end. And for those who get the injection in the middle at 1 year, 12 months time as well. And our outcome of interest is obviously pain, which is collected through 6 months questionnaires. And finally, we evaluate it at 24 months. Sorry, something. There we go. So if you're interested in participating in Regal trial, these are the contact details. I will put them in the chat as well, and you can contact us directly. We've also had PPI input from Endo UK, and one of our patient and public members have helped us create a video, a short video, which I may be able to play at the end. So moving on, when it goes about pain management for recurrence, so there are multiple steps. It is almost like a pyramid. I think one of the key things with endometriosis is education, patient education, knowing your symptoms, knowing what works for you and what doesn't work for you, what are the side effects of various things, and how you can self-manage. A lot of people, well, we've got anecdotal evidence that a lot of people feel that symptoms are better if they change their diet. So like healthy eating, avoiding processed foods, alcohol, decreasing sugar. Similarly, exercise can improve symptoms by releasing endorphins, and stress reduction. Now, it's very easy to say stress reduction. Today's life is stressful, but it is about trying as best as you can. And sometimes some other methods, such as psychological input through cognitive behavioral therapy or acceptance-based therapy for pain, can help, and treating depression and anxiety at the same time. Otherwise, there's a risk of going into a vicious cycle. So pain management can itself quite be daunting, and often it requires input from pain specialists. There are 3 kinds of pain. So nociceptive pain is like inflammation. For example, if you have a cut and you have a pain, that's what nociceptive pain is. Neuropathic pain is nerve pain. So it's more like tingling and burning. But there's a 3rd category of pain, which is called nociplastic. This happens when there's a long-term pain condition and it alters the way that your nerves perceive the pain. So you feel more pain even with less stimulus. And this is more difficult to manage. And that's when neuromodulators come into play, or tricyclic antidepressants. You might have heard of things like amitriptyline, nortriptyline, gabapentin. These are all used for neuropathic and to some extent nociplastic pain. Now, when people come back with pain, while a lot of times we would think it's due to endometriosis, but it's very important to be mindful that there are other coexisting conditions which could cause pain. And some of them commonly coexist with endometriosis, especially adenomyosis. The main symptom of adenomyosis is heavy and painful periods. So painful periods is also a symptom of endometriosis. So it can easily overlap. And similarly, adenomyosis can cause painful intercourse. There are other conditions, especially when people feel pain with full bladder, that's interstitial cystitis. And IBS also coexists in a lot of women with endometriosis. So, as we say, prevention is better than cure. If we can prevent recurrence, that is ideal, but that's not always possible. And there's some risk factors for recurrence. So one of the main reasons for recurrence is incomplete first treatment. So if you did not have all your endometriosis excised or treated at the time of first surgery, the likelihood of recurrence is higher. And that's why it's higher in stage 3 or 4 endometriosis, because it's more difficult to treat that. But BSGE centers have the expertise to treat stage 3 and 4 endometriosis. Similarly, younger age at diagnosis, now it's a bit of a catch-22. If you know when you're young and you're diagnosed with endometriosis, it's likely to be perceived as endometriosis being the cause of recurrent pain. But for a lot of people, it takes such a long time to diagnose endometriosis that they've not even reached the stage of diagnosis. Recurrence can only happen after diagnosis. So that's one of the factors. So there's some factors which do decrease the risk. For example, post-op hormonal treatment, which we talked about earlier, pregnancy. So it's not very well understood, but something changes. The environment in the pelvis changes, that women who've had pregnancy tend to have delayed recurrence, not always, but sometimes. And it also depends on the type of surgery. As I previously said, hysterectomy with removal of ovaries is associated with reduced risk of recurrence. And similarly, if you have a cyst related to endometriosis known as chocolate cyst, cystectomy, which is removal of the cyst, is better than just draining it or burning it away. So with regards to prevention of recurrence, the evidence we have is really low quality. It's sometimes conflicting, and at best, I can say it's inconclusive. So there have been some papers and reviews about recurrence following post-operative hormonal suppression, and all of them found that there is a decrease in risk of recurrence if hormones are used after surgery. But they could not tell which was the best hormonal treatment. And for that, we were doing another trial, which has now been completed. It is known as PREEMPT trial, prevention of recurrence, where we were comparing progestogens in the form of Mirena and Depo-Provera versus the combined oral contraceptive pill after surgery to see which one is better to reduce recurrence. The trial is complete and the results are due to be published soon, but not quite available yet. So until then, how should we treat recurrence? Well, I think there are basic principles. The number one is try and reduce it by completely excising the disease at the time of first surgery. Consider post-operative hormonal treatment if someone is not trying to get pregnant. But most importantly, it requires a bespoke care package for each individual based on their preferences, their tolerance for various treatments, and includes a lot of patient education and self-management. So the ultimate thing is shared decision making, and a lot of times your gynecologists, your endometriosis nurses, support groups, and Endo UK can help you do that. I think that is my presentation. So if we have time, I would quickly like to share the video, which has been, and we are very grateful to Britt for creating that for us. It is about the Regal trial. So I'll try and do that now. Can you see the video?
Yes. It hasn't started yet. Oh, here we go.
Endometriosis is a long-term and painful condition that affects millions of women and those assigned female at birth worldwide. It occurs when tissues similar to the lining of the womb grows outside the womb, causing symptoms such as chronic pelvic pain, period pain that interferes with your daily activities, painful intercourse, and in some cases, fertility issues. Now, we understand that dealing with pain and discomfort from endometriosis can be physically and mentally distressing. We would therefore like to tell you about Regal, a research study comparing 2 treatments for those who have had the reoccurrence of pain after surgical treatment for endometriosis. This research study is necessary because there's just not enough evidence about how best to treat reoccurrence. Regal is currently enrolling participants whose pain has returned following surgery to treat endometriosis. And we know that everyone's experience with endometriosis is unique, and we want to understand which treatment works best. If you're interested in participating in this research, please do visit our website to see if you meet the criteria, which we've also outlined for you at the end of this video. Thank you so much for considering participating in this important research.
Right, thank you. I will stop sharing my screen now.
Thank you. Thanks very much. Thanks very much, Lucky. Is it okay if I start asking some of the questions that have come up in the chat?
Sure.
Okay. So the first question is, can taking HRT cause menopause flare-ups?
So HRT is to improve menopausal symptoms. It does not cause menopause flare-ups.
Okay, thank you. And what can you tell us about the use of metformin to help reduce pain and increase fertility? Is it available in the UK?
So metformin is used in the setup for PCOS, for fertility, and also is a drug to treat diabetes. So there's insulin resistance in PCOS. It is not used in endometriosis. The drug is widely and readily available in the UK.
Next question. Could I ask, what are the treatment options if you have endometriosis return after a total hysterectomy?
So by total hysterectomy, I think it is that meaning total removal of ovaries at the same time? So when we say in medical terms total hysterectomy, we mean removal of womb and cervix. If it's also removal of ovaries and pain returns, it's usually pain management, because most of the times the disease itself will be inactive due to lack of estrogen, unless you're taking some other estrogen supplements. So not HRT, because HRT does not stimulate endometriosis. It has much lower dose of hormone. It's only if you're taking high doses of hormones, especially estrogen, that pain can come back. But it's also important to exclude other causes such as adhesions and any other cause for pain.
Next question. What are the signs and symptoms if endometriosis has come back if you've been on the mini pill for several years after endometriosis surgery?
So the symptoms are usually the same symptoms. So painful periods, painful intercourse, chronic pelvic pain, pain other times of the month, pain when moving bowels, if it was affecting your bowels. That's usually happens in grade 4 diseases. So that's the way of recognizing that endometriosis might be coming back.
Mm-hmm. Okay. Next question. Can medications such as Prostat help pain caused by adenomyosis?
Yes, that's a really good question. So what Prostat is actually a GnRH analog. It not only suppresses endometriosis, but also suppresses adenomyosis. So yes, it does tend to improve pain, both due to endometriosis and adenomyosis.
Okay, next question. Is there any indication of which hormonal options are most effective in reducing recurrence? E.g., is microgynon a good option here?
Sorry, say that again. Is there any
Is
evidence?
there any indication of which hormonal options are most effective in reducing recurrence? E.g., is microgynon a good option here?
So this is what I just discussed in my presentation, that all hormonal treatments are good at reducing recurrence. And once the results of preempt trial are available, which is comparing oral contraceptives, that is, one of them is microgynon, versus others, we will know which one is the best. But yes, microgynon does improve symptoms and reduces recurrence, but what we can't tell is if it's better than others or not at this point at least.
Okay. All right. Next question. Waiting lists are very long, so access to BSGE gynecologists are limited. Are there any plans to educate GPs or other medical professionals on endometriosis to offer more support options outside of specialist consultation?
So this is already happening. In each hospital, you would have a gynecologist who would have interest in endometriosis. Some of the cases can be managed locally, and if they feel it is quite complex, they will refer on to BSG center. But there is definitely education going on both for GPs as well as for secondary care, which in most hospitals you will have a gynecologist who undertakes this kind of surgery. They may not do the most complex ones, which is done in BSG centers, but would be able to manage other minimal, mild, moderate disease.
Next question. Can you elaborate more about the reoccurrence of symptoms after pregnancy?
So recurrence of symptoms are the same as I previously discussed. So the indication is if your periods start becoming more painful, if you start feeling pain during ovulation, if sex starts getting uncomfortable, if during periods it hurts to pass poo or pee, these are all signs that endometriosis could be coming back.
Okay. Next question. Can HRT be linked with the reoccurrence of endometriosis?
So HRT alone is not linked with recurrence of endometriosis. So while endometriosis is estrogen dependent, there is what we called estrogen threshold theory. So to activate endometriosis, we need much higher levels of estrogen, which is present in premenopausal women. HRT is much lower level of estrogen, and it is not able to activate such as endometriosis or growth of fibroids, but is enough to reduce side effects of menopause and protect your bones. That is why when we give you GnRH analogs to suppress your ovaries, we give a little bit of HRT to reduce the side effects and prevent thinning of bones, while at the same time not reactivating endometriosis.
Next question. For surgery for milder endometriosis, is excision, I think that's how you pronounce it, better than ablation?
So that is still a debate that's ongoing. And the main reason for that is we do not have enough evidence from the small research trials that have been done. So one of the other studies, which is studying whether to treat or not to treat minimal mild endometriosis, is also collecting data on excision and ablation. So we are likely to have this answer in the future, but until now, the evidence says that they have a similar efficacy.
And the next question, why is the cutoff age 49?
Regal trial.
I think so. It says, why is the cutoff age 49? I am interested by over, I think it means I am interested but over the age bracket.
So the way it's for the trial, I guess the question is for Regal trial, where the age range is 21 to 49. What GnRH analogs do is they mimic as if you're going through medical menopause. An average age of menopause is 51 years. We're going to be giving it for 2 years. So what we are trying to avoid is people who are naturally menopausal getting the trial treatment, and that's why the cutoff age is 49.
Okay. Next question. What is the UK equivalent for Lupron, and how helpful is it in success of frozen IVF transfers?
So for
Sure.
frozen IVF transfers, I don't think we can address this question for
No. For that particular question, I'll ask the specialist nurse at Endometriosis UK. Okay. Are there any specific treatment pathways for fatigue caused by endometriosis/adenomyosis?
So not yet, but this is now well recognized that fatigue is very, very common and can be a debilitating symptom for those with endometriosis. So more research is needed in this area, but there hasn't been done much. So there aren't any pathways, but at least there's recognition and people beginning to acknowledge that this fatigue is due to endometriosis. We need much more for endometriosis. We don't have answer for so many questions. So research is vital when it comes to endometriosis.
Right, next question. Can I just check, when we're talking about endometriosis recurring, we're talking about the recurrence of what the endometriosis causes, e.g. growth of new lesions, etc. So we live with endometriosis, and if it continues to cause, e.g. growth of new lesions, cysts, etc. after surgery, that's what's reoccurring, the lesions, etc. Just thinking about the changing understanding around migraine, moving towards talking about someone having migraine and then have migraine attacks of various frequencies that could become chronic, and how that changing understanding and how it's talked about links to changing the approach to treatment options, greater support from health services, and a more holistic approach to helping people managing migraine.
Yeah, so that's exactly what I was talking in my presentation, having a holistic approach when dealing with recurrence of endometriosis. And when we're talking about recurrence of endometriosis, first of all, we're talking about recurrence of pain. At that point, it is not always clear if it's definitely due to endometriosis or there could be some other causes for pain which needs exclusion. But a lot of times it is very similar. People can tell that it is very similar to what they were having when they were first diagnosed: period pain, pain during sex, pain during ovulation, and a holistic approach is needed, which includes patient education, self-management, treating the disease, but also treating pain, and a whole lifestyle changes. So yes, I agree. So this is what we are moving on towards, a holistic approach.
I'm not sure if this question is relevant to the webinar, but I'll ask it anyway. Are you more prone for OHSS in IVF if you have endometriosis?
No. Well, it's not related to recurrence, but you're not more prone to OHSS if you have endo. If you have PCOS, yes.
Okay. Next question. Is it safe to leave endometriosis post-menopause? I'm not sure what
that's a really good question. So we know that endometriosis is, when I use the word benign, I'm not saying its impact is benign, but it's not cancerous. So while it causes, significantly impacts quality of life, it tends to wither away after menopause. And it's not necessary to treat endometriosis after menopause, unless you're getting symptoms or you have a large cyst, which we might have to address, but usually it's safe to leave it alone.
Okay. And how can you tell if reoccurrence of pain is from adhesions or return of endometriosis?
You can't always, but I think it is about the nature of the pain. If it's very cyclical, it's more likely due to endometriosis because it responds to the fluctuations in the hormone. If it's constant, because adhesions are there present all the time, it's more likely to be due to adhesions.
Next question. Is the coil an effective method of pain prevention?
Yes, it is. So like any other hormonal treatment, coil is one of the methods, which is Mirena coil. So it's a hormone-related coil, which is effective for reducing recurrence. When we talk about reducing, we are not saying it will completely prevent recurrence. None of the treatments completely prevents it. So pain can still come back. It depends on individual profile as well, but they're all effective.
Okay. Next question. Why does pregnancy lessen symptoms of, I think they meant to type endometriosis. So why does pregnancy lessen the symptoms of endometriosis?
So during pregnancy, there are very high levels of progestogen hormone in our body. The ovaries are suppressed at that time as well, so they're not secreting the estrogen. So lack of estrogen and high progestogen, the same principles which are used in the contraceptive pills or Mirena or Depo apply, causes endometriosis lesions to shrink away, so they're not active and not painful. That's why pregnancy improved. People feel symptoms are much better during pregnancy, just the high hormone state with progestogen.
Thank you. I have had endometriosis return post-surgery after doing IVF treatment to freeze my eggs. Would doing another cycle of egg freezing worsen the symptoms and potentially worsen my endometriosis?
So freezing of eggs alone doesn't, but I believe the person is asking whether having another round of IVF, which includes giving the drugs in this, in some people it can worsen, but usually it's during the treatment time when they're given hormones to stimulate ovaries. But it's again very variable. So I think that it requires discussion with your gynecologist, depending on how you want to proceed. It's not long term. It's only for the duration when drugs are given.
Okay. I've got someone here, so they're very interested in the Regal trial. Will we get emailed back if we email the trial expressing interest, or does it have to be done via our GP?
You can email, I was trying to put it in the chat, but it looks like I have no access to chat, regal@aberdeen.ac.uk. So yes, we get regularly loads of emails from people across the UK, and we have currently 20 sites, nearly 20 sites open. One is about to open, 19 are already open. And we will respond to you and also direct you to the site in your region.
Right. Can you discuss more about reoccurrence if over 50, but menopause has been induced by medication, but reoccurrence is being dismissed?
So it is the treatment of recurrence. So the reason for inducing menopause by medication is to try and suppress estrogen, which in turn will suppress endometriosis. I'm not entirely sure what the participant means. So the whole host of options will be discussed when it comes to recurrence of endometriosis, which includes all hormonal treatments, surgery, and for now, there is an option to participate in the research trial, which is Regal trial, which is open for another year. And then you would be allowed to choose as per your wishes and what works best for you.
What vitamins do you recommend to help with symptoms, e.g. magnesium? Does this help? So
we do not recommend a particular vitamin, but we do focus on healthy diet and a balanced diet. Because some dietary changes can reduce inflammation, and that can in turn help symptoms of endometriosis, even though the disease is there.
Okay. Okay, next question. Digest has been shown in studies to be efficient in suppressing endometriosis. Why, after excision, has endometriosis come back?
So Digest is effective. So after excision, if you are not on any hormonal suppression, whether it's Digest or any other hormonal contraceptive, the estrogen from the ovaries can stimulate growth of new lesions or some microscopic lesions that could not be seen at the time of initial surgery can grow back, or new lesions can seed in. So that's why there is no cure for the disease. It keeps coming back. It feeds on the estrogen secreted by ovaries.
Right, next question. Is the level of estrogen in the combined pill low enough to prevent recurrence? It's somewhat confusing that endometriosis thrives with estrogen, yet estrogen pills are used as treatment options.
Yeah, that's an interesting one. It's a really good question. So the way the combined pill works is actually by suppressing the ovaries and also having a high amount of progesterone in it. And that's why it's effective. So even though it does have estrogen, it is counterbalanced by the progesterone in it.
Okay. Next question. Why is it so difficult to get an appointment with a gynaecologist if my symptoms are back and recent scan shows endometrioma?
So that's a difficult one to answer. It depends on where you're located, and your GP might be able to help you answer that, because it's most likely if you have an endometrioma and your symptoms have come back, you'll be referred on to gynecologist. So I'm not sure which region they are from.
Okay, next question. If you have been on GnRH injections for 6 months without HRT, is it recommended to have a bone density check?
Not at 6 months. So we can use GnRH analogs for 6 months without HRT, but people still get side effects. So, and we stop after 6 months to prevent further loss of bone mineral density. You do not need a DEXA scan at 6 months, but if you need to use it further, you would need HRT. Or ideally, the best way to do it is to have HRT as you start the injection so that you don't have the side effects.
Okay, I'm not sure we're going to be able to answer this question in this webinar, but I'll ask it anyway. Why is endometriosis not classed as a disability?
So I think the way disability, there are lots of chronic conditions. Let me give you some examples. So there's inflammatory bowel disease, there's rheumatoid arthritis, there's osteoarthritis, and different people are impacted in different ways by endometriosis. Some may have no symptoms, some can lead a very fulfilling life, and for others it's absolutely debilitating. So it's as a condition itself, you cannot call it a disability. The disability is how a person is affected, so which needs to be assessed by the occupational therapist.
Okay, next question. Is it important to have regular scans after surgery to monitor endometriosis coming back after surgery, bearing in mind some women don't have any pain at all?
That's correct. So if you do not need regular scans, because some people, if you have no symptoms, you really do not need any monitoring. We only need to treat endometriosis if it is impacting your life. We do not need to treat it if it's just there and not affecting you. Another important thing to note is ultrasound scan can be completely normal and when endometriosis is present, especially for the peritoneal endometriosis, which is more like lesions or like rash on the surface, which you can't see on ultrasound or even MRI. It's only the cysts that you can see on ultrasound, and those who have the expertise can also see bowel disease, but MRI is more often used for bowel disease, but regular monitoring is not required.
Next question. What are the options when hormonal medications, surgery and holistic approaches are unsuccessful?
That is a very difficult one. So a lot of self-management, and with chronic pain conditions, despite everything, some people will struggle. So we just have to try and make get the symptom control as best we can, given that there is no cure. So it's not an easy one. You would need a multidisciplinary approach for that to tackle the specific aspects of symptoms.
Next question. Are there any supplements that can be recommended? My symptoms have returned post-surgery and pregnancy. I don't want to treat it with hormonal treatment as I am planning on trying for another baby next year.
So as I mentioned in my presentation, it's generally healthy diet, what we advise, a balanced healthy diet, no particular supplements as such. There's not enough research, though you will see a lot of things on the web. Exercise, mindfulness, reducing stress, having a good sleep hygiene, all these things help to manage the symptoms. So I think that's what we would say.
Next question. What stage of endometriosis is it if it's on the rectum?
So if it's just like spots on the lining, the peritoneum covering the rectum, it can still be early stage. But if it's deep endometriosis with your rectum stuck to the back of the womb or invading part of the rectum, then it is grade 4 endometriosis, or moderate to severe at least, depending on the extent of involvement.
Okay. Next question. After excision surgery, can it be that there is no relief felt and pain is still there during periods?
That is possible, especially if there is a coexisting condition known as adenomyosis, which itself causes painful periods. It is also possible if other mechanisms of pain are working. So what we call as nociplastic pain. So your sensation of, or the way the nerves carry pain impulses has changed. Your body perceives more pain than the stimulus. So again, a multidisciplinary approach, pain management program, involvement of pain specialist is needed.
Okay. Next question. Is Asherman's syndrome related to endometriosis?
No, it's not related to endometriosis, but related to other treatments within the lining of the womb.
Okay, next question. If menopause was hormonally induced, how can you tell if it is endometriosis and you aren't being dismissed due to medically induced menopause?
Well, my first question in this case is, why would menopause be medically induced? It would only be medically induced for a treatment of a particular condition. So in the first instance, only if you have pain and there's a suspicion of endometriosis and you're approaching menopause, this may be an option offered to you. It's not about dismissing endometriosis, it's one of the treatment choices for managing symptoms of endometriosis.
Okay. Okay. Next question. I was diagnosed with endometriosis in 2015 when I had a cyst and fallopian tube and ovary removed. In my 30s and 40s, I suffered terrible pain with my periods and eventually had an ablation to ease the extremely heavy periods in 2008. Now I am postmenopausal at 58 years old. I do not get periods anymore, but I am concerned what has happened to the endometriosis and if it could turn into anything more sinister. Also, could the ablation cause scarring that could be sinister? What procedure would I need to do to find out the extent of the endometriosis, or is it something I should not be worrying about?
So if you do not have symptoms, there is no need to worry about endometriosis. As such, endometriosis does not turn into cancer, except we know that there is a small risk of slightly increased risk of ovarian cancer in those who have endometriosis compared to those who do not. But there is no test to diagnose that, and the risk is only very slightly increased compared to those without endometriosis. So again, nothing else needs to be done. It is, if you don't have symptoms, you shouldn't worry about endometriosis. And scarring from ablation, endometrial ablation, which is for heavy periods, that is within the lining of the womb, that is on purpose. The scarring is the treatment to reduce heaviness of periods. Again, it does not turn into anything sinister. It's a very commonly used treatment.
Okay. Okay, next question. What options do I have next? As I have already had the endometriosis survey last May, and my symptoms have gradually been getting worse and worse the last few months. Now that it has been 17 months since my operation, what can I do next to help with the pain, as painkillers don't help?
So this is exactly what I was talking about in the presentation. For a lot of people, symptoms will recur within the first year, and for most, by 2 years, they would have had recurrence of pain. The treatment options obviously will need to be discussed with your gynecologist, and also depends on whether you're trying to get pregnant and what hormones you can tolerate or not. So you'll be offered all the same choices you were offered before, but this time you can also be offered GnRH analogs because we know you've had endometriosis, or you may be able to participate in research trial Regal if that's of any interest to you.
Okay. Next question. I did a laparoscopy in January 2022, but now I feel worse than ever. My sex life is worse. I have little or no urge for intercourse. I'm trying for conception, but nothing is happening. What can I do?
So if you're trying to get pregnant, obviously hormonal treatment is not suitable. I think the best option would be to get referred to the fertility clinic. We do find that in some people, surgery does not improve pain, and that's when we wonder if the pain was definitely due to endometriosis, or endometriosis was a chance finding and pain was due to something else. So that's another, you also need to explore that there are no other causes for pain, but get referral to the fertility clinic.
Okay. Okay, next question. Is it normal to have pain after 9 weeks post-op from excision surgery?
It depends on the kind of pain. If you've got pain in your scars, and depends on how much excision was done, what areas were excised. It could be pain from surgery or some degree of persistence of pain, but you should speak to your surgeon.
Next question. I might not be pronouncing this correctly, but can the Mirena coil cause similar pelvic pain to endometriosis and also hair loss as side effects?
So Mirena coil does not cause similar pain as endometriosis, but some people do get crampy pain. So Mirena is like a foreign body within the womb. Womb doesn't like it. It cramps, trying to expel it. For most people, it will accept it and then the cramping will stop, but for others, it won't. So Mirena coil, in a small proportion, they find it painful and it has to be removed, but the vast majority will find it helpful. Hair loss is one of the rare side effects of Mirena.
Okay. Next question. What diet changes are linked to reduction of pain? Which main ones would you recommend?
So there is lack of research in this area. The evidence is mainly anecdotal. What people report is changing their diet, eating healthy diet, reducing processed foods, sugars, alcohol. All this helps.
Thank you. Is it safe to take progesterone only pills for long periods of time, 10 plus years? Can it affect fertility?
It's very safe to take progesterone only pills. So it has one of the least side effects profiles. It can be safely taken until menopause. It's not known to affect fertility. So your fertility returns to your original level after stopping it.
Okay, next question. I think they meant to write when the menopause and after menopause is over, will endometriosis pain be reduced? I think that's the question.
Most people find symptoms improve after menopause.
Next question. Can endometriosis cause other disorders such as chronic fatigue syndrome?
So there are some chronic syndromes which are linked, but it's you cannot say that it causes them, but some other chronic pain conditions, fibromyalgia, chronic neck pain, other inflammatory conditions are more commonly found in people with endometriosis, and there may be a genetic predisposition for these kind of inflammatory or chronic pain disorders. Again, research is lacking in this area, but endometriosis is not a cause for these conditions. There may be associations or coexistence.
Right, it's